Okay, we have a nice big crowd here today. I hope everybody's doing all right. It's a pretty day out. And I'm just about ready to get started here. So here we go. Good morning all, and welcome to the Ask the Doctor Zoom discussion with Dr. Matthew Pianko. For those of you that don't know me, I'm Michelle, or Mickey, and I work with Sid Moss at Cure Multiple Myeloma Corporation. Before we begin, I'd like to ask you to keep your devices on mute unless you want to speak. That cuts down on interference noise. Dr. Pianko is Clinical Assistant Professor of Internal Medicine, Division of Hematology, Oncology, Rogel Cancer Center, University of Michigan Medical School. Dr. Pianko's work is focused on the care of patients with plasma cell disorders such as multiple myeloma, smoldering multiple myeloma, asymptomatic multiple myeloma, I just lost my screen, Mingus, plasmacytopenia, POEMS syndrome, and light chain deposition disease. Dr. Pianko is interested in research and development of the clinical trials of novel drugs and novel drug combinations for patients with these disorders. Before we begin our discussion, I'd like to thank our very important partners, Oncopeptides, Karyopharm Therapeutics, Sanofi, Adaptive Biotechnologies, Amgen, and Dova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to introduce Sid Moss, Sid, wave, the founder of Cure Multiple Myeloma Corporation. Sid and his organization are responsible for these great breakfast treats. So, Sid. Before we begin our discussion with Dr. Pianko, I'd like to introduce Elaine McNally, NP, Head of Advocacy Medical Affairs for Oncopeptides. Elaine is going to speak a few minutes about her team and the work they've been doing. So welcome, Elaine. Are you there?
Good morning to you. I am here.
Okay, there you are.
Hi, can you all hear me okay? Great. Thanks. Oh, thanks for all the reaffirming nods this morning. Thank you. Well, like Mickey said, I am proud to represent the Oncopeptides team this morning. And like Mickey said, I am a nurse practitioner. What Mickey didn't mention was I live in California, so very early morning to me. And I don't jump out of bed normally this happy, but I was thrilled to do it this early and this happily for Mickey and to meet you all in the greater Detroit area. So good morning.
Morning.
Anybody complained to me about getting up early? No, just kidding. Good morning. So I'm happy to represent the team, and we are so thrilled to be your platinum sponsor this month and every month, and happy Myeloma Awareness Month. I won't take too much time because I know we want to get to the main event, Dr. Pianko. I'm eager to hear your presentation as well. But I would like to tell you all a few things about Oncopeptides. Number one, I'm going to try and share my screen if that's okay, Mickey.
Yep.
Thank you. Number one, Oncopeptides has been around for a long time. I don't know if you all know how to use the Zoom or if you just want to do it with your faces. Have you ever heard of Oncopeptides before? Maybe you can, no, yes, no, I'm looking for reaffirming faces. Well, Oncopeptides is a very small company based out of Sweden, but we have a strong and mighty presence in the United States. We just have a brand new approved medication for relapsed or refractory multiple myeloma called Pepaxto. You might have heard of it as melphalan or melflufen. We decided to just make as many names as we could to confuse everyone. Just kidding. So Pepaxto is the new drug, and I'm not going to spend any time talking about this agent today. I'd rather spend our time talking about the resources that we have available for patients. The first resource I'd like to share with you, and all of these links that I'm showing you, Mickey has will share with you after the meeting and in the newsletter as well. So don't feel like you're missing out on anything if I'm going so quickly. We do have a resource called OnCourse, which for any patient who is prescribed Pepaxto is able to find financial assistance, either insurance support, financial assistance, and other resources. And that's called OnCourse. Get it? Oncopeptides, OnCourse. So that's easy to remember. And then another resource I'd like to share with you is There is a patient-friendly website. If you'd like to learn more on your own time, you can look at the Pepaxto patient website. And then another resource, which Mickey was kind enough to share in the recent newsletter, is the myeloma channel. And this is a resource for patients who are relapsed or further along in their myeloma journey. And there's lots of great resources, including, but not limited to, some patient interviews, a patient story, which I think we all learn a lot from hearing the stories of other patients. So that is the story of oncopeptides and our recent approval. But perhaps the very best resource in the whole country is your team in Detroit. And I know most of our team is on the call. I'm sure you can see the gallery view, but we've got Maria Cass, who lives right there in Detroit area, and she is your local representative. And she just gave you a wave. Good morning, Maria. And then on other parts of our team, we've got Chelsea Boggs. I can see Chelsea.
Hi.
Here she is. And then I don't see Betsy on my screen, but that might just be my own. Oh, there she is. She was on page 2. Hi, Betsy.
Hi.
So Betsy is your medical science liaison. Now, I don't believe any patient would probably reach out to any of those folks, but you're welcome to, number one. And then you can also share with your healthcare provider that Oncopeptides has a dedicated team in the Detroit area to serve you and the myeloma community. But perhaps no other dedicated team in Detroit other than Mickey and Sid. So I would like to thank you for your great work. It has been such a pleasure to get to know and work with Mickey over the last couple of months, and learn about your winter activities, what you do over there, and all of that white stuff that falls from the sky that we don't know what that is here in the Bay Area. So I'd like to congratulate you, Mickey, on doing a wonderful job for the whole Detroit community and for the whole myeloma community, and you as well, Sid. And thank you for including us in your community and your family, and for this opportunity this morning, especially for Myeloma Awareness Month. So that's all I wanted to share about oncopeptides. You can reach out to me at any time. As you can see, I'm open 24 hours a day. So anytime, feel free to contact me. And with that, I'll turn it back to you with a big, huge thanks and a virtual hug to you, Mickey. Thank you.
Well, you're welcome. And thank you. I mean, we really, really appreciate your support, because without the support like this, we couldn't do these kind of discussions and have our programs.
We're thrilled to be supporters, and thanks for including us.
So moving on, the way that this is going to work is Dr. Pianko will provide us with a little background on himself for those of you that don't know him, although I think most of us do, but there are some new faces on today. And then he'll give us an update on treatments and any other news as it relates to multiple myeloma. Then we'll open it up to questions from you. So please use the chat button to type in a question anytime during the discussion, and I'll make sure that I bring it up. I'll read all questions sent to me in advance too. We've got a few. They're all almost the same, but we'll ask those questions too. And then at the end, make sure that we will have time so we can unmute and actually just talk too. So with that, I guess we'll just start the discussion. So take it away, Dr. Pianko.
Great. Well, thanks again to everyone for joining, and special thanks to Sid and Mickey and the Cure Multiple Myeloma Corporation for hosting these breakfasts. I think they're really a great resource. And thanks again to our sponsors for helping make these sorts of events possible. I think it's a great way to have, conversations with our patients, outside the clinic, and sort of learn about what's going on in myeloma. So thanks again to everybody for joining. Overall, just to introduce myself, I'm a hematologist at the University of Michigan with focus in multiple myeloma. I've been at U of M about almost 3 years now, and been excited to start my career here after finishing my hematology oncology training at Memorial Sloan Kettering in New York. I've got some background in Michigan. I was an undergraduate here, and my wife is from the area, and I'm a Midwesterner at heart. I grew up outside of Chicago, so moving back to the Midwest was a nice place to be, close to family and in familiar grounds to start my career. So I think it's been great so far at U of M, and I've had a wonderful experience so far. Getting into meeting many wonderful patients and being able, having the honor to care for many patients with myeloma so far. So, lately, I think what's been really exciting about what's excited me about myeloma care and what's been really encouraging in the last many years is that we keep having new options that come out for myeloma. So I think that there's lots of exciting new developments in the field, and I think that there continue to be new great options coming for treatment, and I think it's an area that has experienced a lot of innovation. But for which there still really remains a great need to expand, what we have to offer patients. So, namely, I think, some of the things that have been, at least in my experience so far, like, some of the more exciting things that are coming down the road are, some of the expansion of immune therapies for multiple myeloma and ways that we can, try to harness the power of the immune system to attack myeloma. And so, many of the developments in this category of drugs have really focused on trying to impact various ways that we can have the immune system in some ways wake up and recognize myeloma cells as being bad and as being targets to be eliminated. And I think that many of these have focused on this way of sort of highlighting what's different about myeloma cells than normal cells, normal plasma cells, and what distinguishes them from other cells in the body is there have been some developments looking at this protein BCMA, which is a protein that's on the surface of myeloma cells and helps drive the growth of myeloma cells, and is something that has been a broad target for new myeloma drug development. So many of you have maybe heard about CAR T cells or chimeric antigen receptor T cells. These are a kind of a modified T cell treatment that are in development currently, and there have been a number of studies that have been completed so far, and I think that it's possible that sometime in the next couple of years that we might see this expanded to be an FDA approved treatment. I think that this is something that is not, I think, generally available yet, but is really only available in clinical trials for myeloma. There are some CAR T cells that have been approved for other types of blood cancers. I think that these sorts of options are generally exciting. It's like a living drug that once given sort of stays active in the patient and tries to keep myeloma under control without the need sort of for ongoing drug treatment infusions. I think we had hoped that the CAR T cell options could offer sort of lasting control of myeloma. We do see that, at least based on recent studies and data, that the responses seem to be lasting about a year. But I think there's still more information that we have to get about why certain patients would have shorter versus longer responses, and how to manage the potential side effects. And I think they're exciting but potentially complicated therapies to give. So I think that for resources for CAR T cells in the area, I know U of M has a CAR T cell program for myeloma, as well as Carmanos down the road in Detroit. And so, I think if this would be something, I think, to discuss with your care providers, if that's something they think you would potentially benefit from. But again, it's sort of only something that we have available in clinical trials, but could be coming sometime in the next couple of years. I think that the estimates are always hard to give, because I think there's lots of variables, including COVID, which we'll get to, that have kind of impacted development and availability of some of these newer options. So I think another sort of way to get after this BCMA target, which seems to be a good way to find myeloma cells and eliminate them. If you just get rid of all the cells that have BCMA, there are not really other cells in the body that you need that you're killing. So I think it's a neat target for myeloma. But the question is, with CAR T cells, there's a lot of preparation that needs to happen. There's a lot of coordination. The cells need to be prepared. They need to be sent off to a facility to be manufactured. This can take a number of weeks. they then need to be sent back to the facility where you're being treated, and everything sort of needs to be arranged. So it just takes a lot of coordination. So I think the idea is, is there other ways to go after this protein that could be something you could pull off the shelf and wouldn't require so much resource and so many resources and so much lead time. And so there have been some ways to develop engineered antibody type drugs that bring the myeloma cells that express BCMA close to the immune T cells, which, if they're brought right up next to the myeloma cells, using these types of drugs can induce the T cells to start killing the myeloma cells. And so there have been a number of companies that are developing, this sort of approach where it's an antibody type drug. It's an infusion. And it's almost like a double-sided Velcro strap, where one side grabs the myeloma cell and the other side grabs the T cells. And when you bring them that close together, the T cells end up recognizing the myeloma cells as being bad and start attacking them. So there have been a number of studies that have been carried out with drugs like this. There's a number of companies that have developed approaches like this, and this is another exciting area that I think are showing promise for people who've had myeloma that's come back after a number of prior therapies. And I think that I think what's fascinating is to see how these immune therapies might be integrated earlier into treatment plans once I think there's an FDA approval, and once sort of other trials suggest that these drugs could be used earlier. I think there's immense power in the immune system to be able to potentially help with treating myeloma. So I think that that's in addition to that, I think there's a couple new drugs that have been approved in myeloma. One of which was mentioned earlier, the Pianko drug, which was very recently FDA approved, and other agents, Blenrep or belantamab mafodotin, which is another antibody drug conjugate against BCMA, as well as selinexor. These are sort of all new players in the field. So I think there's a lot of neat ways to consider using these new agents. It would be one where I highly encourage the integration of sort of new drugs into your treatment plan, and sort of when to use them is something that is definitely something to discuss with your treating physician. And I think if your primary oncologist isn't a myeloma specialist, I think it's always a good idea to have a myeloma specialist on your team. So I know at our center we're more than happy to work with local docs and sort of help co-manage discussions and help think about picking drugs, and so we're sort of more than willing to help. I think to pause for a moment. Any sort of questions about new sort of myeloma treatments? And I know that obviously I think the big topic that we're all thinking about still is the impact of COVID-19. So I think I'd like to spend a couple minutes on myeloma treatment, take some questions on this, and then if there we could maybe move on to talk a little bit more about how COVID fits into the myeloma world, and how how to think about the vaccines and other topics related to COVID. So any specific questions? I see that in the chat there's some questions about the vaccines, and I'll cover those. But any sort of questions about new myeloma treatments at this point?
I have to say that every question that I got was about the COVID treatments. So if there's somebody else too, Kevin, did you have a question?
No, not at this time. Not at the moment.
Oh,
okay. Okay. Well, feel free to drop a note in the chat if there's a question about that. So I guess to switch gears and to discuss what's come the role of the COVID vaccine. So there are as you all I'm sure know, there are 3 vaccines that have been designated for emergency use authorization by the FDA. There's 2 messenger RNA vaccines, the Pfizer vaccine and the Moderna vaccine. And then there's another viral vector vaccine, the Janssen or Johnson & Johnson vaccine, which have recently been released. So, I think at this point in time, our recommendations are that, really everyone should get vaccinated. I think that there are some considerations, with regard to treatment with myeloma that are, I think, important with regard to the vaccines. But I think that at this point in time, there's not any, specific contraindications to getting the vaccine unless you've had an allergy to, exactly one of the vaccine components. So we've been encouraging our patients to, try to get vaccinated however possible. And I know that vaccine supply has been a big problem, and that trying to get access to the vaccine has been inconsistent across the state and really across the country. But I'm hopeful that in the coming months, if any of you haven't had a chance to get vaccinated yet, that hopefully that becomes available to you. So I think that the important question one of the important questions is like, how effective are these vaccines? And so the large vaccine trials really excluded anyone with immune compromising conditions. And so there were not patients with multiple myeloma who received the vaccines in the large studies to demonstrate that it's efficacy in myeloma patients. At this point in time, I don't think we have any concerns about the safety of the vaccinations. I think that we wouldn't expect there to be more side effects in myeloma patients compared with people without myeloma. I think that just the main question is how well the vaccines might work. And I think that this is something I think no one has data on yet. So I think there's really been no information about vaccination success rates in myeloma patients, and I think that it's something that has been definitely a need. So I think there's great challenges in sort of getting that information. I think that when it comes to looking at what constitutes a vaccine response, are there tests that we can send to evaluate if there's been a vaccine response? So it's a complicated question. So there are antibody tests, all of which are not created equal, which can try to measure the body's production of antibody proteins against the COVID spike protein. So the spike protein is the part of the COVID virus that binds to the human cell and helps get the virus into the human cell. So this spike protein is a rational target for the vaccines, and is what has been targeted with many of these vaccines. And so the idea in part is that if you can block, if your body makes antibodies that block the piece of the virus that is needed to get into the human cells, that could quote unquote neutralize the virus and prevent the virus from taking hold in the body. And I think the whole idea with the vaccine is that if we can make our bodies generate antibodies that can intercept the virus, then that's a way to help generate protection. So as some of you may know, the way that our body generates antibodies is when someone gets a vaccine or they get an infection, the body takes the pieces of the proteins that are either produced by the infection or experienced through the vaccines, and tries to generate these proteins that stick to those shapes that they've seen previously, and then tries to make cells that are capable of generating antibodies going forward. And so some of those cells are called B cells. And over time, B cells can transition into being long-lived plasma cells. And so plasma cells, as you know, are the tumor cells in multiple myeloma. And so it's rational to think that there might be some difficulty in producing antibodies over the long term in patients with myeloma, because the tumor cell is sort of one of the cells that can be important for antibody production. There can be normal plasma cells that coexist in your body if you have myeloma with the malignant plasma cells, and I think that for those who are have less myeloma around due to treatment and maybe being on maintenance therapy, there may be more of those normal plasma cells around that are capable of producing antibodies. So we do see that when the disease is more active, that sometimes the normal plasma cells can be inhibited or crowded out by the malignant plasma cells, and we think that that could be a factor in impacting the effect of vaccines. So I think that an important issue is that at this point in time, I think that myeloma patients can respond to the vaccine, but there are some potential implications of the treatments for myeloma, as well as the disease, as well as age. All of these things can impact people's vaccine responses. So at this point in time, at least what I've been doing in my practice, and what I've been interested in at U of M is, our immunologists have developed an antibody test that measures antibodies against the spike receptor binding domain, which is the exact piece that locks onto the human cells to get in, and that is a test that I've been sending in some of my patients who've been vaccinated to try to see if they make antibodies against this protein. So I think there are some important caveats that I discuss with patients when I'm talking about this test. So the presence of antibodies doesn't necessarily guarantee protection. It's possible that there are antibodies that either weakly bind, or maybe present in small enough amounts, and maybe are detectable but not enough to cause full protection. So there's not really, I think the takeaway point is there's not, I think, a test currently that's clinically available that your doctor can order and give you results for that will prove 100% that you're protected. I think that we what I've been using the antibody test for is in a way to try to understand if my patients have had antibodies, and if they do have antibodies, I think it's encouraging, but it doesn't necessarily, I think, at this point in time, as we're still learning more, I try to, have a discussion with my patients about, still having some caution about taking precautions with masks. And I think that as we learn more, and as more of the population gets vaccinated, I think that this would probably be a discussion you just want to have with your doc about sort of your what sort of after the vaccine, how you should act, and how, like, what to do. And I think this is an area that we're still learning more about. I think that to speak to some of the unknowns, so I've been working on a couple studies at U of M, collecting some of the antibody test information to see, for some of my patients, and some of our patients who have received vaccines, who are under our care, when they got the vaccines, what type of vaccine they got, and trying to see if we could save some of their extra serum to send for antibody testing. And that's something I'm working on with the immunologists. I think that that's something that is sort of after the fact. So it's something that, if we're measuring their myeloma proteins with the serum protein electrophoresis, and the same lab that measures all the M proteins for myeloma is the one that does the antibody test. So they've been helping, I think, store some of this, leftover serum that would otherwise be discarded. And those people that I'm able to send antibody tests, I'm trying to have them use the tests and then try to save some leftover serum for sort of future testing. And so the idea is that, okay, well, if I mentioned that this antibody test doesn't totally prove that you're protected, is there anything else that could be done to evaluate this? So from a research perspective, there is, but from a clinical care perspective, that there isn't an exact test, I think, that's readily available. So to elaborate, in some of the vaccine studies, the way that in the lab, some of the pharmaceutical companies have evaluated the immunogenicity, or the ability of the vaccine to induce an immune response in the patients, is to take their antibodies and say, can it actually neutralize the virus? And so the way of doing that is to take the antibodies, take the serum from a patient who's been vaccinated or exposed. And what you can do, I've been working with a collaborator at U of M whose lab has worked on developing this neutralization test. And so what that is it takes pieces. Sorry, Sid, did you say something?
No, I'm talking about my wife.
Okay, sorry. So the way this viral neutralization test works is that they take the spike protein from the coronavirus, they take the genetic material for it, and they basically put it in a different virus. And so it's like they force the other virus to have the spike protein from the coronavirus on the surface, and that way you're sort of working with like a dummy virus that is safer to work with in the lab, but still has pieces of the coronavirus on it that you can use to see if your antibodies will neutralize or inhibit that virus. And so there's a way to test serum against that dummy virus to see if it's able to inhibit it. So I'm hoping that with some in the future, with some of the samples that we've been able to store, that we can try to evaluate that to see if if the serum can inhibit the virus. And what's neat about that particular test is you can also take the viral variants, meaning many of you may have heard of some of these viral variants that are coming around from like the UK and South Africa, where there's been variations in the spike protein that have maybe influenced the behavior of the virus. And one of the neat things is about this neutralization test is that, since you can really plug in the pieces of the virus that you want to plug in, you can actually take the genetic material from the variants, from the spike protein from the variants, and try to see if the antibodies that are made will knock out the variants too. And so the trouble, or at least, the important background with this is I think that, while I know that we're all like so hungry for a return to normalcy, and I think we all wish that there could be like a test that could say, okay, so my serum protects me from all the variants. Like I can, go back to, doing whatever I want to do without wearing a mask and interacting with everybody. And so I think that the challenges are with these research tests, that since it's not something that is really, these tests they're done in a research lab, they're modified, they're not totally, I think, certified. There are strict limitations with the sort of information that that researchers can give to patients based on research testing. So there are some, these sort of research tests have to be like strictly vetted and like evaluated and run in like a certified lab. And so I think the important take home is like this viral neutralization test. There's not a version of that at least that we have at U of M and that I'm aware of that's readily orderable by clinicians to sort of test this like neutralization capacity, which would be the most encouraging proof that your antibodies would really stick to the virus and knock it out. So I think that's sort of, the initial, sort of work that's going on. And, I know that through some of our communications, I've been working on developing a companion study to this, where we try to collect samples from patients, before they get vaccinated, during the vaccination, and after the vaccination, to sort of look at the B cells, to collect the serum beforehand and after. I'm interested in the role of our gut microbes in influencing immune responses. So we had some efforts to collect stool to look at the gut microbiome. And largely this part of my research has taken a little bit more time to get open than I would have liked. And so I think that the challenges are that I haven't really been able to collect samples on that particular study. And the pace of vaccination is now moving really fast. I'm hopeful that I can get some patients on that part of the study, but without it being open, I can't really consent anybody to really collect samples on that yet. So that's been a little frustrating, but things have been moving, quite fast. So I think that if I, hopefully I can get this open in the future, and I can certainly communicate with Sid and Mickey and with Mary Norat from the myeloma support group to sort of spread the message out about when this study might actually be open. But I think the other things I'm thinking about down the road is, well, if it's looking like the majority of the population is going to be vaccinated soon, and hopefully all of you can get vaccinated soon, I think the next questions are going to be, if we weren't able to collect samples beforehand, is maybe to think about, well, okay, for those of our patients who do get the vaccines and who don't make antibodies, what should we think about then? And I think that that's also an important question. So I think that probably there's more to say about this, and I'm thinking about ideas which would include some sample collections after the fact, and I think that naturally one would think trying maybe if you got one of the mRNA vaccines to say, well, if we try the other type of vaccine, maybe that would work, or do we need a second second series of boosters? I think that these are all interesting ideas, but there's sort of no information yet out about this. And I think the other great challenge is that at least with the scarcity of vaccines and their availability so far, the idea of running a study where you have vaccine supply that you can then give to participants as part of the study is something that's really, I think, not currently feasible, just because there's such I think a nationwide scarcity of the vaccines. This could be something that later on could work out to say, if you failed, or if you had a set of the mRNA vaccines and had both of your doses and didn't respond or didn't make antibodies, and there's reason to suspect that you may not be protected, what to do then? Would an additional series of vaccines make sense? It's possible, but there's really not any information to justify doing that, and I think certainly now it'd be hard to get another series. But maybe sometime later in the summer or the fall, when there's more supply, that could be something that could be explored. I think that the other part I want to say is that these antibody tests are not 100%. So I know through speaking with colleagues of some people who are on some of the vaccine clinical trials who went and got some of these antibody tests afterwards, and that not 100% of them had antibodies necessarily. So I think that the important part is that all these antibody tests, like, they're not identical. Each one may have some subtle differences. Important to know is if the antibody test is against the spike protein, or is it against this other protein called the nucleocapsid protein, which is a protein that's really only in the virus. It's not in any of the vaccines. And so that's another type of antibody test that's been developed that really proves that you were previously exposed, but doesn't necessarily, wouldn't necessarily show a response to vaccination. So I think the important take home from that is, like, if you are thinking about getting an antibody test, with your docs and wherever you're getting treated, that they're sending this spike protein test, and then to keep in mind that there are these caveats, that it's not, if you don't make antibodies, it is still possible that your T cells, the other, major aspect of your immune system that controls against infection, like those could have made a response to the vaccine, and you might have T cells that recognize COVID, even if your antibody tests are not positive. So it's possible that even if your antibody tests are negative, you still might have some measure of protection. But it's tough. I think it's tough to sort of interpret, the response to the vaccines at this point, with all of the newness of the vaccines and the differences in the tests. So, I think it's reasonable to talk with your doc about getting an antibody test if you've had the vaccine, but it's by no means I think a standard recommendation for that everybody, that all the providers are doing. So I think it's likely gonna would be an individual discussion with your doc, knowing that there are these caveats, that it's not 100% guarantee to show protection, and that if it's not positive, that there is still some benefit that you might have had vaccines that's just not measurable with that test. Sorry, I sort of said a lot there, so I want to maybe pause and see if there are any sort of initial questions about what I've said, and then I'll be happy to start working through some of the questions that have been placed in the chat.
So one question that has come up before that I've seen a few times is about the antibody test. If, say, you have multiple myeloma, you get the vaccine, you then go and have an antibody test, and it tests, and the test results show that you may not be protected. You spoke about another test that you're doing at U of M. Would it be a good idea, or would you suggest that maybe people get a different kind of antibody test so that their doctor could look at both? Is that something that's suitable?
I think that I think it depends on what kind of antibody test is being done is the important question, and just to be sure about what type of test was sent. So really the only test that I'm sending that I think has clinically available results is this antibody test against the spike protein or the receptor binding domain, or the RBD for short. And I think that it would just be important, I think, for you and your provider to know exactly what type of antibody test is being sent. Because if you get the vaccine, let's say, and then you go get an antibody test, but they measure the antibodies against the nucleocapsid protein, well, that protein's not part of the vaccines. So that test should be negative if you haven't had COVID, but it wouldn't measure the antibodies that the vaccine is making your body produce. So I think that knowing exactly which type of test is being sent would probably be the first part to be clear of. And I don't think there's another test that I would recommend sending. I think the important part is just maybe the time frame. So I probably expect the maximal antibody response to be happening about probably 4 to 6 weeks after the second dose of the vaccine. So I think that I would probably get the vaccines and then wait at least somewhere in the 2 to 8 week range after the second vaccine. I've been trying to target about 4 weeks after the second dose, if there are 2 doses, to measure it. And I do, our patients have been responding to the vaccines, not 100%, but there are patients who are on Revlimid who've been responding. There are patients on daratumumab-based regimens who've been responding. I think another important question is, is there any modification of your treatments that could be considered? So, largely the only really basis for recommendation, the International Myeloma Foundation released some vaccine guidance to providers that would suggest at least the steroids, you could hold them a week before and a week after the vaccine doses. And I think that that's something that came out, recently. So I have had patients who've been on steroids when they got vaccinated and they've had responses. I've had other patients who have held steroids and not had responses. So I think that it's a recommendation, but I don't know, how strong that this exactly needs to be followed if it wasn't necessarily the case. Let's say you got your vaccine and, we didn't know that, these recommendations were released sort of quite recently. So I certainly had some patients in whom I haven't necessarily held steroids in all the patients who've been vaccinated, but I think it's something that could impact the vaccine response and could, temporary hold in steroids, for the purpose of getting your vaccines. I think it'd be something to talk with your doctor, because I think everyone's situation is unique. And it could be something that could impact the response. Apart from that, I think other than that, I don't think there are any, universal recommendations to sort of hold, various treatments like, daratumumab or Revlimid or pomalidomide. There are some data that suggests that Revlimid can potentially help vaccine responses. This is some older data, and there's also just some conflicting trial results on that. So there's some trials that for patients who are on Revlimid maintenance after their stem cell transplants, had greater influenza vaccine responses compared with those who were on observation. This is older data for when we had enough patients that didn't do maintenance to be able to do that kind of study. But I think I know at least of another study where they tried to replicate that result and couldn't. So I think that there's mixed data on whether or not the myeloma therapies, would either help or harm the vaccine responses. But anecdotally, in sending the antibody tests, I have had a fair amount of patients on daratumumab who've been making antibodies. So I tend to really the drugs that I'm thinking about modifying when I'm discussing the plan with my patients is probably just the steroids at this point in time. But I think it's always an individual discussion, and one that you should have with your docs. So sorry, sort of a long-winded and answer to your question, Mickey, but I wanted to elaborate on maybe what some of the reasons why, if it is negative, maybe it's not the right test, or if it's negative, is there anything else modifiable? And I think that really the unanswered question is sort of what to do after that. Should someone get a second vaccine? I think there's not any information about that, and of course, vaccine availability is tough. So I think going and getting a second vaccine is not easy. So I hope I answered that question. I think just to address some of the questions.
Oh,
Sorry. Okay. Was that Stephen? Did you have a question?
no.
Okay. To address some of the questions in the chat, is a spike in light chains and creatinine common after having COVID-19? So I think COVID-19 can cause a lot of inflammation, which our plasma cells, both normal and myeloma plasma cells, can respond to inflammation. So it is, I don't know if it's necessarily common, but I do anecdotally, and sometimes in my patients who've had some kind of infection, sometimes see that their myeloma numbers can be up a little bit after the infection. But it's sort of hard to say if that's necessarily common. I mean, I think we've had such a wide variety of HAL and such responses to COVID among patients, where some patients, they don't have they're not too sick, and other patients who are very sick. So I think there's such a wide variety of responses that's probably a hard question to answer generally. But sometimes infections can rev up the immune system in a way that has the light chains perk up a little bit after an infection. Mr. Brooks asked about, he mentioned getting the Pfizer vaccine. He had some pain in his hands. I think that muscle pains, if that's was in the area where there's muscles or not in the web of his hands, I think there have been some myalgias that have been reported, or muscle aches that have been reported after some of the vaccines. But usually this have been mild and time limited. And I think, so far, just to sort of step back, I do think that everyone should get the vaccine. that the potential complications of getting COVID are so severe, especially myeloma patients, that if really the likelihood of any sort of vaccine side effect being severe enough to make me think twice about it recommending to a patient. Really, I highly recommend, if you haven't gotten vaccinated, go try and get vaccinated. Some of the data from many of the early studies and reporting how myeloma patients do with COVID suggests that there is really high complication rates and really high rates of death. So I do think this is a potentially life-saving intervention. And, I think that I highly, encourage you to go get vaccinated if you haven't already. Really have not been hearing about severe, side effects in our patients who've been vaccinated. It's been really, really just some minor reactions, muscle aches, maybe feeling a little bit fatigued. But I encourage you to, talk with your doc about it if you have any concerns. So I think that Marcia asked a question about the COVID vaccine efficacy in a patient who maybe didn't respond to the strep pneumoniae vaccines. So the strep vaccines are these polysaccharide vaccines, which are sort of notorious for having less profound immune responses, especially in immune compromised patients. So I think that because the COVID antibodies, the COVID vaccines use a completely different technology, I think that it's hard to really extrapolate that. So it's possible that the strep pneumonia vaccines work a little bit less well and are less effective than the COVID vaccines. But I don't think there's any data. So it's certainly possible that someone who didn't respond to one type of vaccine, particularly the strep pneumonia vaccines, could still have a vaccine response to the COVID vaccine. So I wouldn't, get too discouraged in that particular scenario. Back to some therapy questions. So Scott had asked if some of the newer treatments that I described earlier, the BCMA drugs, would replace drugs like Revlimid or work alongside of it. So I think that that's a very interesting question. I mean, I think that Revlimid can kind of activate, certain aspects to the immune system. And so there are certainly, there'll be probably future studies that would explore, how these drugs fit in alongside Revlimid. I think the advantages of Revlimid, obviously, it's an oral tablet. So if you need like a maintenance drug, a drug that's oral is quite appealing because you don't necessarily have to go in for infusions and you can have it mailed to you and take it at home and all that's like very convenient. So some of these other drugs that I'd mentioned, I think are sort of unlikely at least to replace Revlimid as like more of like a maintenance treatment for most people. But I think that let's say for, CAR T cells, after you get the CAR T cells, there's currently not really any maintenance treatment that you need. Usually the CAR T cells are staying active in you. And so that's in some ways, could, for that particular patient, who would otherwise be thinking about Revlimid maintenance, if you get CAR T cells, you wouldn't necessarily need maintenance, at least not with the information we have so far after getting CAR T cells. So I was also asked about, our experience with Darzalex. So Darzalex is this monoclonal antibody drug, also known as daratumumab, which has been approved for multiple myeloma in many different settings, both in the relapse setting in combination with many other myeloma drugs, Revlimid, pomalidomide, carfilzomib, and then in the upfront setting for newly diagnosed patients, in combination with Revlimid and dexamethasone for those who are ineligible for transplant. And there are some encouraging data about daratumumab being combined with RVD for newly diagnosed myeloma patients based on a phase 2 study. These are exciting, but this part isn't really yet FDA approved. In general, I find daratumumab to be a very effective myeloma drug and is one that's really quite well tolerated. Especially convenient is the new subcutaneous version. that instead of having a 90-minute infusion, is really a 5-minute injection, and is really similar in the scope to Velcade. So you could go in and just get your injection in your belly and go home. And I think that's really, saved people a lot of time, and it's been very popular in our clinic. And so overall, I think it pairs well with the other myeloma drugs and doesn't seem to have significant side effects, apart from lowering of some of the blood counts early on. And there is some increase in infections that we can see with daratumumab due to its suppression of some certain cells in the immune system. But generally, those have been, sort of mild infections. And again, it doesn't seem that, I've had a variety of patients who've been getting vaccinated and some on daratumumab, and they've been making antibodies. So I think that part has been, I think with regard to the question of if the daratumumab suppresses the immune system, would that inhibit the vaccine response? So I think that there's was a question about honeysuckle flower. I'm actually not too familiar with that, but I'll have to look through the reference in the future. Marcia, your next question is excellent. So I think the other part that's important is, so if the COVID vaccines are not 100% in myeloma patients, and there's a possibility of not having a response, I think it's really important that your close contacts get vaccinated. And so the more, insulation and protection you can provide with your family members, the better, the better for you. I know another important question that I will just, address outright. There is obviously, I think we're all, like, many of us have grandkids, and many of y'all have grandkids. And I think the question is, well, if their vaccines haven't been approved yet for kids, and they haven't had studies for kids, and potentially for kids, younger kids, into the fall, we may not expect them to get vaccinated for a while. I think it's a really tough question to say about, how safe it would be to, interact with your grandkids. And I think that's probably, an individual question you probably have to talk with your family and your docs about, and think about the risks and benefits of it. It seems like, the young kids are not really at significant risk of COVID. But that has, I think, supported many of them going back to have in-person instruction where possible. But I think the hard part is going to be knowing, exactly kind of when's the right time to be able to sort of relax some of the restrictions. I think that's such a hard question, and is probably one that's, individual. And I wish I could, give you all like a really encouraging answer to say, oh, totally no problem. But I think it's something that would probably be an individual discussion with your treating physician and your families about what's the right approach for that. I really think that hopefully with expansion of the availability of the vaccines, we can really try to work to get everybody vaccinated soon. And I think that hopefully as more of the population gets vaccinated, we can have more and more protection from COVID and less cases around. I know that we're currently experiencing another spike in Michigan based on recent data, which is discouraging. So,
I don't even know if I believe it's an upturn in Michigan.
Sorry, could you repeat that?
I think that was just someone speaking, but I can't even see who it was right here.
Well, hopefully expansion of the vaccinations can hopefully turn, this latest increase in cases around, so that there's less of an impact and compared with prior spikes. I think the last, part that I think could be interesting, but, isn't sort of currently available is, so there are some of these antibody treatments that have been developed based on for COVID that almost are like pre-produced antibodies. I think currently these are really only available for people who have active infection. I think an interesting idea could be, whether these could be applied, for patients who don't make their own antibodies to provide some sort of passive immunity. I don't know of any studies to date that have been carried out or are open exploring the use of these sort of approaches, but that could be something that for people who don't make responses to vaccines, could be a way to, if we're not going to, if a second vaccine is not going to work or isn't successful, maybe providing some sort of passive approaches, could work. Looking ahead, I'm, more than happy to, answer any questions that come up about this. And, I'm very interested in this. I sort of wish my own vaccine study had, to prospectively collect the samples had been able to sort of open fast enough, but hopefully I can get it open sometime in the next, few weeks, but it's just taken a lot longer than I had hoped. So, hopefully I think my next steps can be to, look at the responses from some of the patients who've been vaccinated so far and really try to think about ways to, in those patients who haven't had a response, to dig deep into those patients to try to figure out why they didn't respond, to see if we can learn more, and to think about designing approaches to try to overcome failure to respond. I think that a question from Hal is how long after having COVID-19 would be likely to be immune to reinfection. I think that's an open question and probably depends on the variants. So I think some data suggesting that some of the variants people can be infected with one variant and then be infected with a different variant. This is hard to say. I mean, that you're 100% protected from all variants, even after having been infected. So I think even if you have had an infection and recovered from it, I think that there's reason to go get vaccinated anyway. So I would encourage anyone who's here who's had COVID that doesn't 100% mean that you're fully protected from getting it again, and would encourage you to get vaccinated anyway.
So there are a few other questions. Sorry, if you were going to continue on, but I do have a couple that I can see that were direct to me and a couple that were sent in. Should I ask those?
Sure.
Okay. One of them is not COVID related. It's how do you feel about the new therapies that you mentioned and their effect? Let's see, you mentioned affect the ability to assess disease burden in patients.
So to sort of restate the question, so how do we anticipate that the new treatments are going to affect our ability to measure the disease burden in patients?
Yes, I guess that's the...
Okay. Well, I think that the new therapies at this point in time. So I think that the way that we measure the disease burden is by measuring the M proteins, by measuring the free light chains, or in those people who may not have those proteins available. Other approaches might be imaging, or you may be doing a bone marrow biopsy. I don't know that the new therapies would really interfere with our ability to measure the burden of the disease. So I think that we are still able to measure those proteins and in light of people who are getting these antibody treatments to sort of know what's going on with their disease, even if they're getting some of these other antibody treatments. So daratumumab can sometimes interfere with the measurement of the protein electrophoresis. So for example, if someone has an IgG type myeloma, IgG kappa type myeloma, the antibody daratumumab is an IgG kappa monoclonal antibody drug. So sometimes the protein testing can identify the drug and measure the drug, and we might think that it's the myeloma related protein if they have the same type of myeloma. But that's IgG kappa is probably the most common type of myeloma, but still there's only a subset of those who, not all of the IgG kappas, will there be confusion with daratumumab? And so some labs have an ability to distinguish between the two. So I hope I answered your question. But I think most of the time it's not going to interfere with measuring the burden of the disease.
I'm looking through the questions that we got beforehand, and almost all of them I think you've answered already, except the only one, and this has to do with COVID too. Do you have any idea which COVID-19 vaccination is the most effective for multiple myeloma patients? If they had a choice, would you recommend one over another?
You know, that's it's a good question. I think that the efficacy rates from each of the trials for each of these vaccines cannot be directly compared one to another. So I think that probably the most appealing vaccine is the one that's available, the one that you can do. I don't think any one over another is preferable from my perspective. I would just take whichever one you can get. You know, anecdotally, I've been able to measure. You know, we've had more people get the Pfizer and the Moderna vaccines just at U of M. So I think that at least all I can say is that when I've been checking antibody responses, most of the people I've been able to check antibody responses have been with the Pfizer or the Moderna vaccines, just because of the date of release. In terms of, it's just not been enough time yet for most of the people who've got, or the patients who've had the Johnson & Johnson vaccine to make antibodies yet, or to have it measured. So I think any of them are appropriate. So I don't think we have information to say which one would be more effective than another for myeloma patients at this time.
Are there any other questions from the group here? It looks as though you've answered everything that's in the chat right now. And actually, if anyone else has some questions, if you want to unmute and ask them, just blurt them out, because we're kind of running out of, this is about toward the end of our time frame. So if you have a question, please just ask.
I have one.
Okay.
Are there any dietary suggestions that, or studies that have been found, or has there been any studies on dietary as it pertains to treating multiple myeloma?
So I think with regard to treating multiple myeloma, I'm not, aware of any studies of diet and on the impact of diet. I think there was a large study from Europe about I think MGUS and smoldering myeloma. And sort of the impacts of diet. I think it was a Scandinavian population. I'm just going to try to find the paper that I can put into the chat, hopefully. So if you're interested, you could go read through it. But I think that having a fair amount of dietary fiber, I think would be important. So leafy green vegetables, I think would be helpful. I think, generally the recommendations I say are to have a healthy, well-balanced diet as best you can, and try to have some, plants and dietary fiber in the diet. And in a way, I think that this could potentially help, support your immune system. I'm interested in the influence of the gut bacteria on our immune systems. And I think that, really having a diet that, it gives your gut bacteria plant fiber, I think can be helpful in boosting the immune system. Although, that's sort of in the realm of hypothesis still at this point. Sorry, my pager's going off. It's a good question. I can. Know that I can find the paper at handy right now, but I think that generally that's how I usually respond to the question about diet. I think try the best you can to have a healthy, well-balanced diet and include some plant fibers.
So,
or anything you would suggest avoiding?
Not necessarily. I mean, I generally, I think that depends on your immune system and white blood cell counts, where, you know, sometimes I'll tell people to avoid maybe raw food like sushi, for example, if their white blood cell counts are low or they're on immune suppressive medication, but there's not anything I really suggest that people avoid. Sometimes greasy foods can impact people's diarrhea if they're on Revlimid therapy. So sometimes more of like a low fat diet can be helpful if you're having some loose stools with Revlimid therapy.
Thank you.
Great questions. Important questions. I wish we had more data to elaborate on that, but I don't think we have that yet.
Dr. Pianko, if you want to send me the link, I can make sure that everyone receives that.
Okay, great. I'll have to follow up in an email and send it to you once I have a chance to dig through and find it.
Thank you. Thanks a lot.
Yeah.
And
No
I know
problem.
that your pager went off, and we are over an hour now with this discussion. So I think that this is probably a good time for us to kind of make it come to a close. If you know, if there's any, I feel like we probably should let Dr. Pianko go back to his important work. But I want to say thank you so much for taking all this time to be with us today. And I really feel that this is important information for everyone. You know, unless there's something someone wants to say right now, I think that we should probably end this and let Dr. Pianko go on to his patients and getting on with his day. All right. Well,
Which is his life.
Yeah.
Great.
well,
Well, thank you
so much.
Thank you so much. Thank you so much, everybody. Thanks for attending, and thanks for your attention, and thanks for your very thoughtful questions. It was a pleasure meeting with you all today, and thanks again to Sid and Mickey and to our sponsors, and let Mickey know if you have any questions that I can help address. And hopefully it can be a resource to you all as we sort of navigate into hopefully a post-COVID future in the very near future. So let me know how I can be of help.
Yeah, I will. Yeah, if you have any questions, just shoot them over to me. And right now, after we're done with this, I'm going to eat my breakfast.
Eat my English muffins. Thank you, everybody.
Take care.
Thank you.
Thanks. Bye.
Bye.
Bye.